Okay, now my next talk, following the leads of Dr. Hosni, about unilateral pediatric keratoconus. Now, this is a child that presented at the age of 10 back in the year 2018. He had blurred vision in the OD, as we can see. The manifest and cycloplegic refraction showed higher astigmatism compared to the OS. Now this is the pentacam done at the first visit. As we can see for the OD, there's an asymmetric bow tie while the OS is completely normal. Other variables such as the Kmax 51.4 and thinnest location with Y shift more than 500 microns. The total D was 3.75 and the back elevation was plus 26. So actually the patient was diagnosed as keratoconus grade 2 in the OD, while the OS was completely normal. So the obvious is this is a case of unilateral pediatric keratoconus, and according to protocol we cross-link immediately. We do not wait for progression like with adult keratoconus. So the usual protocol, which is not our case today, we cross-linked the OD, the right eye, with the accelerated protocol AP off, and it has to be AP off technique. The first month follow-up, the patient had haze of grade 1, which is quite normal with the AP off technique, and the patient with 1 year 8 months follow-up, actually now he has more than 2 years of follow-up. The haze cleared and the best corrected distant visual acuity improved to 0.8 after dropping in the first month follow-up. And this is a serial pentacam showing the change in the phenotype of keratoconus diagnosed from this is the first one and this is the last one, number 4. The Kmax actually did not change. The astigmatism changed from 5 to 4.2, and this is the change of the topographic shape or the abnormal topography from first to the last visit. As for the bilin and bruisio, some changes were recorded. The D value actually increased. The ABCD grading, which is excellent tool for progression of keratoconus or even post-LASIK ectasia, now that we have the software to assess the post-LASIK ectasia with both ABCD and Corvus. The green flags, they represent the normal population, while the green flags, they represent the keratoconic population. The first flag represents the 80% confidence interval, and the second one represents the 95% confidence interval. The A stands for cornea in front, B stands for back, C stands for thickness. The columns to the right represents the pre and the first 2 visits, and on the other side represents the last 2 visits. The most significant change, as we can see, with the posterior surface elevation. As for the TBI, TBI is an integrated technology in pentacam and the Corvus machine. The idea is to incorporate the bilin and bruisio value, especially the D value, the total D, and the Corvus CBI or Corvus biomechanical index together. This is a sort of artificial intelligence program to create what's called the TBI or tomography biomechanical index, and it's a way for measuring the keratoconus, early diagnosis of corneal ectatic conditions, or even following the progression of keratoconus, or even cases suspect with post-LASIK ectasia. Back to our case, the changes actually were minimal for both the CBI, the T, and the TBI index, and for the other eye it's completely normal. The serial pentacam and the bilin and bruisio is completely normal. even the ABC is completely normal for the other eye. So we're subjected with a case of pure unilateral pediatric keratoconus. So the idea is, whenever having a pediatric clinical keratoconus is for cross-linking and follow-up, but actually unilateral keratoconus is extremely rare, and every case of keratoconus should be considered bilateral, and you should keep following up the eye. Now this patient had almost 2 years now, more than 2 years of follow-up, and the other eye is completely normal. So what's wrong with this case? Actually, this is not a case of unilateral keratoconus. This is a term called induced mechanical ectasia. It was described by Dr. Renato Ambrosio and some authors back in, I think, 2017, when a case of unilateral corneal ectasia diagnosed like this case. Actually, this is not a keratoconus. Dr. Gatinel from France is basing his keratoconic theory on mechanical theory, which is rubbing, eye rubbing, and there's what we call the June violet month for keratoconus, which is keratoconus awareness, to instruct especially young children to stop rubbing their eyes. So this was a case actually of induced mechanical ectasia, and this case was not for cross-linking, aiming for preventing progression. However, it can be done for refractive reasons. Refractive cross-linking now is a hot topic, but this was not the aim, or cross-linking was done for this case. So we have to confirm if we are subjected with such cases. Does the patient has any mechanical stimulus like eye rubbing, even sleeping in a dependent face-down position? Some reports recorded that this might induce corneal ectasia. We must record what's called longitudinal data collection, which is actually follow-up of the patient. CBI and TBI, as we mentioned in this case, and they were completely normal for the OS. And a very important tool, which is the epithelial mapping. Epithelial mapping is very, very critical for early diagnosis of possible, or what we call keratoconus suspect or not, sorry. In case of induced ectasia from mechanical rubbing, the most preferable solution is actual follow-up. Some cases, if they are not pediatric ectasia, if they are adult, we might refer to intracorneal ring segments, or even topography-guided surface laser vision correction, which we can do it more comfort way, not fearing that this is a case of keratoconus. Thank you.